So I'm Shauna O'Hearn. I'm the Director of Global Health at Dalhousie and have had the honor of working with Neil over the years in this role and in different roles that he has had. So it's been fun to be part of the planning of this conference and thinking about what this plenary could be exploring and talking about this morning. So we had a good warm-up yesterday with Michael Clark and Cicely McWilliams, who talked to us about equity, and Michael really gave us a good starting point of thinking about how do we define equity and how do we start to measure it. And I think we're going to see and hear a little bit more about that today in the presentations and hopefully continue to have some of those discussions. I can see them in the back, so I anticipate some questions later, Michael. And Cicely began that conversation, which we're going to be exploring this morning, around gender equity. She brought it into the lens of thinking about child rights and children as agents of change. And today we're going to start our conversation in thinking about gender as a framework within global health. The whole topic today in this plenary is meant to be about gender equity and ethics, some of the frameworks that we use when we're working in this area of international and local global health work. So I'm hoping that Carol is online, so this is the fun. So we trialed it yesterday. Carol's actually in Costa Rica. She is an adjunct professor at the School of Epidemiology, Public Health and Preventative Medicine at University of Ottawa. She has extensive work experience, over 17 years with the WHO, where she spearheaded the first initiative on gender issues. And she also has, before that time, worked with IDRC and with CETA as well. So her work had the strong lens of thinking about gender, thinking about it from a population health perspective, and we're really looking forward and very happy that she's able to join us through Skype, and hoping that it's working. So she's going to come on, we're going to have her presentation, and she's going to be in the background through the whole panel and then be part of the discussions afterwards.
Well, good morning, everyone. And it's a real pleasure to be able to participate in this conference, even though it has to be from Costa Rica, which isn't too bad either. So I'm going to turn off the video, and I'm just going to speak from my notes, and you'll be able to follow along on the slides, if that's all right. So I'm going to talk about gender equality in health systems research in lower and middle income countries from a human rights perspective. In the presentation, I'll briefly review the state of research on gender equality and health systems in lower and middle income countries in order to assess how well health systems are actually responding to the needs of their clients. And I look at this question from a human rights perspective, arguing that attaining full equality should be the goal of all gender, health, and human rights related research, in which really the right to health is fulfilled by states and enjoyed by people, regardless of gender. And I think to say at the outset that this is a time of tremendous world turmoil and flagrant abuses of human rights. We know that individuals are often put to considerable peril just because of their gender. Many gains that have been made over the past decades have been swept aside in a relatively short period of time in several countries, and racism and hate have become the new norm in some parts of the world. So I feel that this is all the more reason for gender health and human rights researchers to focus on a goal. And the goal, I feel, should be gender equality in health systems, and to identify what research needs to be done in order to reach this goal. Next slide, please. My objectives today are to introduce health as a human right and how gender equality is a key component. Secondly, to demonstrate that gender-related health research is presently stalemated and to suggest why. And thirdly, to recommend a framework to streamline and prioritize gender and health systems research toward the overall goal of gender equality in health. Next slide. First, let's review what we know about health as a human right. And this is quite familiar, I think, to most of the people in the room today. But I think it's always good to review. Next slide. First of all, human rights are transformative. And if you don't remember anything else from this presentation today, remember that. Human rights seek to fundamentally change the power relations in society which serve to disempower certain groups or deny them their ability to exercise, claim, and enforce their human rights. And as one researcher, Melinda Jones, put it, the concept of human rights signifies the idea that society should not just recognize and accommodate difference, but the society should be transformed by the inclusion of that difference into its daily modus operandi. Next slide. The right to enjoy the highest attainable standard of physical and mental health was enshrined in the Constitution of WHO at its founding in 1946. It was further elaborated in the Universal Declaration of Human Rights of the United Nations in 1948, which also guarantees women's rights. The declaration was signed by almost every country in the world, and a number of world conferences and international conventions have also reinforced these rights and required that women be protected from any interference in their fundamental freedoms and human dignity. Next slide. The right to health includes reciprocal relationships shown here between the duty bearers, which is really the state, and the right holders, individuals and groups. So the duty bearers are legally bound to fulfill their responsibilities towards the right holders, while the right holders must be aware of their own freedoms and entitlements. Next slide. The highest attainable standard of health is assessed by 4 benchmarks, which I'm sure are very familiar to you: availability, accessibility, acceptability, and quality, or AAAQ. Availability means that functioning public health facilities, services, goods, and health programs must be available in sufficient quantity throughout the country. And accessibility entails that people have access to these facilities. Economically, they should be affordable, for example. Physically, it should be within a reasonable, reachable distance for everybody. And informationally, they should provide information that people can understand, and non-discriminatory, so everyone has equal access, regardless of gender, race, etc. Acceptability requires that health facilities, services, goods, and programs comply with medical ethics and are culturally appropriate, while quality entails that they are of good quality and that they should comply with scientific and medical standards. Next slide. Within the international legal system, governments have the primary responsibility for implementing these human rights, and they have 3 fundamental duties: to respect, protect, and fulfill human rights. Now, some of these rights had immediate effect at the time of signing, while others have the caveat of progressive realization. The provision for progressive realization, however, was based on the premise that not all governments were immediately ready to furnish all AAAQ compliant benefits, so that in some cases certain rights needed to be implemented gradually. However, all states are obliged to move steadily forward. They are not allowed to go backward or lapse in their commitments. To examine gender and health systems from a human rights perspective, then, let's think of the duty bearer as the health system and the rights holders as its clients. Next slide. The right to health contains 5 core obligations 3 of which are solely the responsibility of the health sector. These are access to discrimination-free health facilities, goods, and services, access to essential drugs, and the equitable distribution of all health facilities, goods, and services. The other 2 core obligations, access to nutritious food, and to safe and potable water, as well as to shelter, are shared with other sectors. So here, in this presentation, I'm focusing really on the 3 core obligations exclusively belonging to the health sector. Next slide. The human rights principle of equality and non-discrimination is shown here. All individuals are equal as human beings and by virtue of the inherent dignity of each human person, and all are entitled to their human rights without discrimination of any kind as to race, color, sex, ethnicity, age, language, religion, political or other opinion, national or social origin, disability, property, birth, or other status. Next slide. Therefore, it seems evident that our vision should be to focus on gender equality as part of the fulfillment of human rights, and that everyone is equally deserving of AAAQ. Next slide. Now let's look briefly at the state of gender-related health research, starting just with a very brief overview. Next slide. Up to the 1970s, a male model of disease prevailed in pretty much all areas of health, except for the reproductive period, where women's issues received most of the attention in the research, and especially related to family planning, pregnancy, childbirth, and maternal child health. But in the late 1970s, researchers started realizing that male-female differences were in other areas of health as well, and especially recognizing it in the experience of illness, so that men and women may experience illness in the same way, even though the disease at that time was thought to have exactly the same impact. Nonetheless, the main focus even of this type of research was on reproduction, but it expanded to broader areas within reproductive health, such as maternal mortality in lower middle-income countries, service delivery, access issues, and so on. In the 1990s, the international development literature gradually shifted from a focus on women in development to gender in development, and to incorporate questions about the broader determinants and consequences of male-female differences. The first major initiative was in the Tropical Disease Research Program in WHO, which began to look at issues relating to the impact of tropical diseases on men and women, including but not just limited to reproductive issues. Next slide. Guiding this work was a simple framework shown here to help formulate research questions. And it formed and investigated hypotheses from what was already known about health-seeking differences between men and women and other existing knowledge, and applied it to the study of tropical diseases such as malaria, schistosomiasis, leprosy, and others. It highlighted economic, social, and personal issues, including how the sexual division of labor, such as women at home and men in the fields, leads to a differential exposure to disease vectors, or how personal factors such as the different power relations between providers and patients affect women and men's desire to seek health care. For example, research demonstrated that men generally received more health education and positive prognoses than women, who were given instructions to follow rather than real explanations. Next slide. In the early 2000s, we saw an expansion of gender research in health in LMI, lower and middle-income countries, in many non-reproductive health areas, including the so-called neglected diseases, HIV, accidents, mental health, sexual abuse, and violence. Gender in health has become a mine of opportunity for publications in a whole new field of exploration. In parallel, the concern for gender equality in opportunities and access has created a demand in all sectors of society to incorporate gender sensitivity into their programs, supported by a number of UN declarations. So now we see a proliferation of gender research chairs in university departments, gender focal points, as well as a confusion even in the use of sex and gender generally. Often gender is mistakenly seen as a socially acceptable term for sex. Next slide. So from all this research, what do we know about how far we have progressed toward the vision of gender equality? First, how well is the duty bearer, the health system, furnishing its core obligations to its clients in a non-discriminatory environment? And secondly, what does the research tell us about how adequately LMIC right holders are receiving their minimum benefits vis-a-vis gender equality? Next slide. To answer the first question, let's look at the various components or building blocks of the WHO's health system framework. These include leadership and governance, health financing, service delivery, health workforce, medical products, and information. Next slide. The second column shows the approximate distribution of studies published in each field in relation to gender equality. This search is limited to systematic reviews, this particular one, but I'm currently undertaking with other colleagues a more exhaustive literature search. But even from this, we see that most of the research is focused on health workforce and service delivery. And much of the health workforce literature deals with the unequal distribution of men and women in different job categories, female nurses, male doctors, discrimination in the workforce, in the workplace, differentials in benefits, wages, knowledge, and mobility because of women's lesser ability to take advantage of opportunities because of their domestic roles, especially in LMICs. And in the service delivery area, the studies tend to focus on gender differences in how health providers view and treat their clients depending on their gender. For example, female doctors have been found to listen more and give slightly more time to their clients. Also, health workers are more likely to diagnose men earlier than women in services, but men are less likely than women to complete their treatment. The third area, which receives about 20% of research attention, is that of information surveillance, M&E, and so on. And it's widely shown by this research that many countries, especially developing countries, fail to analyze sex disaggregated data, if indeed they have it. And the research in this building block has tended to focus more on tools and data for integrating gender into healthcare. So there's been a lot of research on the development of tools. And this slide also is interesting because it shows that very little attention has been devoted to the other building blocks. So there are really big gaps here. And clearly more research is needed to identify challenges in these various areas. In research on governance, the lack of gender-sensitive medical education, or now called gender medicine, is well documented. And also the need for changes in organizational culture and gender mainstreaming policies. The lack of comprehensive interventions, including greater inclusion of sexually diverse populations, is very notable. Apart from the literature exclusively devoted to LGBT groups, the mainstream research is sadly deficient. In health financing, earlier studies were actually more plentiful previously on gender issues of access, affordability, and so on, such as the impact of structural adjustment. But the current research in this area is really minimal. And similarly in the medical products building block, a field where the male model has predominated throughout history, and scientists continue to ignore females in favor of males. For example, although women suffer more cardiovascular disease than men, they are underrepresented in clinical trials and in the reporting of results. There are very few studies in LMICs of male-female differences in the impact of different treatments for pretty much all diseases. Next slide. I mentioned earlier that most of the research in the area of surveillance, M&E, and research has focused on tools development, resulting in a great many tools for integrating gender equality into health systems. But this slide shows that the tools have mainly gone unutilized by health providers and mainly used by NGOs. And it's remarkable that these methodologies to alleviate the critical consequences that are so well known of post-conflict situations and natural disasters, gender-based violence, that these remain unutilized by the health system. And one methodology, however, does stand out from the ones I reviewed that does have a community focus and developed in South Africa with support from IDRC and TDR, Health Workers for Change. And that continues to be used quite successfully to help health workers identify problems in the system, including gender-based discrimination against their clients. Next slide. So let's look at the second question. What does research say about how adequately LMIC rate holders are receiving their minimum benefits with respect to gender equality? Next slide. Remember these 5 minimum core obligations with immediate effect to right holders. Next slide. Here we omit 2 obligations, as I mentioned, access to safe and nutritious food and access to housing, water, and sanitation, because they're shared responsibilities with other sectors. But we could go into some detail on those because even in these areas we do find major gender differences and major inequalities. But with regard to the other 3 health system obligations, it seems that clients do not feel that their rights are being realized. We see such a long column of no's here. But there is some evidence that female providers are preferred over male, especially for reproductive health services for women, and that female providers listen more and, as I mentioned earlier, give a little more time. And this kind of overlaps a bit with the health system provider and the client recipient. Hard to kind of separate those out in the studies. But they do report very many studies that women feel they are often blamed for coming late to services, despite the many constraints they feel to get there in the first place. And it makes it even more problematic for poor women because they fear ill treatment in the services. Evidence from South Asia shows that male children receive modern health care more than females, including completion of the full immunization schedules. And female appropriate medications are particularly lacking, as I mentioned earlier. And there are many examples of lack of equitable access to good quality health facilities for both men and women often. But these examples abound in the research, yet there's very little research that tries to identify what to do about these well-known problems. Often we seem to be reinventing the wheel. For example, we know that women are more likely than men to go late for malaria detection, or similarly for late reporting for leprosy or HIV testing in some places because of the stigma. We know that gender differences account for this, so why are we not applying that knowledge to find some solutions? Next slide. So I would say that we are basically back where we were in this simple framework, studying a whole number of determinants and consequences with respect to one disease after another. In mainstream medicine, or mainstream clinical medicine, there's a goal to find a cure or treatment, for example, and studies move along a continuum, for the most part, toward this goal, building on previous findings. I would argue that in the field of gender and health research, and in the health social sciences more broadly, we should be doing this as well. Next slide. If we're aiming toward the goal of gender equality in health as part of human rights, We might usefully refer to this continuum, which is a gender integration continuum developed by the Interagency Gender Working Group. It shows 3 different stages in reaching gender integration. First, we have the exploitative phase that reinforces or takes advantage of gender stereotypes. Second, we have the accommodation phase, which works around existing gender differences and inequalities. And finally, the transformative phase, which fosters the critical examination of gender dynamics and strengthens or creates systems to support gender equality. I feel that gender and health researchers fall more into the first and second phases than into the truly transformative one. We continue to exploit the lack of attention to gender in the past and low-hanging fruit such as easy publications and comfortable research positions, rather than identifying and addressing true research gaps, such as some of the areas discussed here today. Next slide. So overall, I would say that gender and health research needs systematization and critical analysis, a new research agenda leaving behind exploitation and accommodation, and moving toward transformational research, and the prioritization of research gaps. I would also recommend giving more attention to the evaluation of implementation research, such as gender equality tools, and identifying where scaling up is justified. And finally, in the support of research programs that use a human rights framework that encompasses sex, gender, and diversity to remove barriers, reduce stigma and inequalities, and improve care. And the last slide. So in conclusion, I'd ask you to consider where your research and or that of your institution is along this gender integration continuum. Where is your research or that of your institution in addressing priority areas from a gender equality and human rights perspective? So thank you very much.
Thank you, Carol. That was great, both in giving us a history and exploring the context of the state and the role of the state, but also in giving us some really clear next steps. I wish you would be here for some of the conversations this afternoon that Jan Hatcher-Roberts is leading on how do we, from this conference, have an action plan of moving forward. So I saw Jan writing notes down quickly, so I anticipate that your words will be part of those conversations and that you've raised lots of points for us to have some discussion after the next 2 presentations. So thank you very much. That was excellent.